Tenho teu corpo e a tua uma adição, na mão e na calma da intuição. Quero esse simples teu livre de ser, quero esse livre tão simples de ver. Quero te ver em teu livre tecer, teu antes, teu hoje, teu simples viver no mar. Tua palma na uma da mão, eu tenho tua mão no meu corpo no chão. Tenho teu corpo e a tua uma adição, na mão e na calma da intuição. Quero esse simples teu livre de ser, quero esse livre tão simples de ver. Quero te ver em teu livre tecer, teu antes, teu hoje, teu simples viver no mar.
Excuse me, delegates, could you please take your seats? And now that you have taken your seats, could you please all be upstanding for the arrival of the official party? Thank you.
Good morning, everyone. My name's Bev Robotham. I'm the Chair of the Federal Council of the Australian Medical Association, and on behalf of Federal Council, I welcome you to the 2016 Australian Medical Association National Conference. The Australian Medical Association, delegates and guests would like to acknowledge the traditional owners of the lands on which this conference is held, the Ngunnawal people. We pay our respects to their elders, both past and present, and all Aboriginal peoples within these lands from whatever Aboriginal nation they may come. May I introduce to you Selina Walker, who will give the welcome to country. You may sit.
Well, good morning, ladies and gentlemen. First, I would like to apologise on behalf of my grandmother, Agnes Shea, who was scheduled to be here this morning to welcome you to country. She's been unavoidably detained, so you're stuck with the younger version. I would also like to acknowledge any other Aboriginal and Torres Strait Islander people that might be here in the room with us today. Welcome, my brothers, sisters, aunts and uncles. The Ngunnawal community are the traditional custodians of Canberra and the region. You may not be aware that the Ngunnawal Nation is made up of several family groups and not just individuals who represent this country. Therefore, as a community, we have an elected body known as the United Ngunnawal Elders Council to represent us, along with the Aboriginal and Torres Strait Islander elected body of the ACT. This is important for you to understand and acknowledge, for our identity is a collective identity. There are other Indigenous and non-Indigenous people from around the country, the nation and the world who have come to live on Ngunnawal land. I would like to acknowledge and welcome you all. The tradition of welcoming the people to country is a practice that was handed down by our ancestors, old people and elders from the beginning of time. Before entering another person's country, you would first announce your arrival and not enter until a traditional owner formally welcomed you. The reason for this practice was to protect your spirit whilst in another person's country and also to show respect for the country of which you were entering. It's wonderful to see that this practice is now recognised and respected. I suppose it's not like entering into someone's home unless you're first invited. The Ngunnawal people, as within all Aboriginal people, have a great heritage that we would like to share with all Australians from every walk of life. As you are aware, Canberra means meeting place. And Canberra has been a place of gathering for many Aboriginal tribes of Australia to come together to do with important business and also for ceremonial purposes. Our Ngunnawal ancestors believed in the importance of people gathering to share knowledge, build relationships, and to celebrate the gift of heritage and history. We believe it's important for all to recognise our unique history and to gain an understanding that our land is our heritage and how loss of the land has disconnected so many Aboriginal people from their spiritual links, cultural heritage and identity. Again, on behalf of my grandmother Agnes Shea, I would like to thank you for inviting us here this morning to welcome you to country, and as my grandmother always does, I will finish in the words of my people, the Ngunnawal people. Yunanga Yerebu Yungu, which means you may leave footprints on our land, or in other words, welcome to country. I unfortunately can't stay for the rest of the proceedings, but I know you've got a full schedule, so I'll zip my lip now and so you can get on with it. I do wish you well for the rest of the day, and thank you again. Sorry, I've got kids. Thank you.
Thank you. That's a busy woman. Okay, I'd now like to introduce Tony Maxfield, who is going to sing the national anthem. Tony Maxfield has more than 20 years' experience as a vocalist and performer. She's a reservist in the Australian Army with the Royal Military College Band Duntroon, and she regularly performs with a variety of Canberra's corporate and jazz bands. Welcome, Tony.
Thanks, everyone. Australians, oh, let us rejoice, for we are young and free. We've golden soil and wealth for toil. Our home is good by sea. Our land abounds in nature's gifts of beauty, rich and rare. In history's page, let every stage advance Australia fair. In joyful strains, then let us sing. Advance Australia fair.
I'd now ask delegates to be upstanding for the official reading of the Declaration of Geneva. Oh, you're still standing. The Declaration of Geneva, the Physician's Oath, was originally adopted by the General Assembly of the World Medical Association at Geneva in 1948. It's been amended in 1968, 1983, 1994, and editorially revised in 2005 and 2006. It is a declaration of a physician's dedication to the humanitarian goals of medicine, a declaration that was especially important in view of the medical crimes which had been committed in Nazi Germany. The Declaration of Geneva was intended as a revision of the Hippocratic Oath to a formulation of that oath's moral truths that could be comprehended and acknowledged in a modern way. So we'll now read the Declaration of Geneva aloud from the slide. At the time of being admitted as a member of the medical profession, I solemnly pledge to consecrate my life to the service of humanity. I will give my teachers the respect and gratitude that is their due. I will practice my profession with conscience and dignity. The health of my patient will be my first consideration. I will respect the secrets that are confided to me even after the patient has died. I will maintain, by all the means in my power, the honour and the noble traditions of the medical profession. My colleagues will be my sisters and brothers. I will not permit considerations of age, disease or disability, creed, ethnic origin, gender, nationality, political affiliation, race, sexual orientation, social standing or any other factor to intervene between my duty and my patient. I will maintain the utmost respect for human life. I will not use my medical knowledge to violate human rights and civil liberties, even under threat. I make these promises solemnly, freely, and upon my honour. I'll now invite the President of the Australian Medical Association to welcome our guests.
Thank you, Bev. Well, delegates, ladies and gentlemen, I would also like to welcome you to the National Conference, my last as Federal President. And we are joined at this conference by a number of special guests. I'd first like to acknowledge the presence of some former AMA presidents at this conference, and I'll ask them to stand as I name them. Would you please make welcome Dr. Bryce Phillips, President from 1988 to 1990. Dr. David Brand, President from 1998 to 2000. Associate Professor Rosanna Capolingua, President from 2007 to 2009. And Dr. Andrew Pesha, President from 2009 to 2011. And finally, Dr. Steve Hamilton, President from 2011 to 2014. The AMA is pleased and honoured to have with us some very distinguished overseas visitors. And as I read your name, would you please come forward to the stage for a gift from the AMA as a token of our appreciation for your attendance here. Please welcome from the British Medical Association, Dr. Andrew Dearden. From the New Zealand Medical Association, Dr. Stephen Child and Ms. Leslie Clark. From the Singapore Medical Association, Dr. Ye Wei Chung.
Thank you very much. Good to see you. Thank you.
And from the Chinese Medical Association, Mrs. Sun Wei, Mr. Meng Kui Lung, and Dr. Gu Fa Ming.
Okay.
Sorry, one for you. Now, these are some of the leading lights in the world, in world medicine, and it's a pleasure to have them here. You will hear more of their experience and leadership and ideas throughout this conference, but please go out of your way to have a chat with them. Thank you very much.
So, AMA presidents do not get to choose the events over which they preside. We ask that they get on with it and make us proud, and Professor Brian Owler has done that for us. We've experienced seismic activity in healthcare landscape over the last couple of years, as have doctors in other countries, as governments struggle with the question of how much they value good healthcare. The President has steered a path for us through these tremors and quakes. Brian, we congratulate you on your tour of duty and we thank you. Ladies and gentlemen, it's my pleasure to introduce this short video which will remind us of the life and times of Brian Owler, President of the Australian Medical Association 2014 to 2016, and I'll invite Brian to address us at its conclusion.
The increase in the contribution from the Commonwealth is going to be woefully inadequate to meet the healthcare needs of all Australians. We have multiple reviews going all at once with no clarity, no endpoint, no vision about what our healthcare system should look like in the future. And I think that is the question that the government needs to answer so that we all know what aim that we're actually working towards.
We're going backwards because of a lack of focus on these issues, but now we're going to be hit with an extra reduction in funding, and that's going to mean that services are going to suffer further.
It frustrates me when people come and create this argument, oh, you just need to be more efficient. I mean, the amount of efficiencies that have been generated by doctors and nurses and administrators in state and territory hospitals has been phenomenal.
What we don't want to see is people taking out cheaper premiums or cheaper policies and then realising that actually private health insurance is not worth it.
Health is not something that we should be reluctant to support. Health is an investment because if we don't have good health as a nation, no other economic activity is going to be possible. The notion that you can cut 600 million plus out of radiology and pathology and not result in either a dilution of the service or costs being passed on to the patients is nonsense. The sheets don't get cold these days because the beds are always occupied. Well, what it really means now is that costs will be passed on to patients. There's no doubt about that in my mind. What it really means is that if you need those essential blood tests, X-rays, CTs, MRIs as part of your care, you're much more likely to need to pay significant amounts out of your own pocket.
This is quackery. This is something that people should avoid. It is dangerous. It makes no logical sense. Having children in detention is a form of abuse. It is harmful to them, both psychologically and physically, and that's been well documented. And this country needs to get all of those children out of detention and back into a safe environment.
There is no doubt that from 2017, funding public hospitals on the basis of CPI and population growth is completely inadequate, and that is what the states and territories recognise.
If we're going to have taxation, we're going to raise revenue, we need to make sure that that is a hypothecated tax, that it actually is for healthcare, not delivering personal income tax cuts as the Treasurer has suggested recently.
Well, thank you. I'm glad John left out the Rick Astley video this year. I'd like to acknowledge the traditional owners of the land and pay my respects to elders, both past and present. Colleagues and friends, it has been an incredible honour to lead and be President of the AMA. The past 2 years have been, to say the least, a turbulent time in Australian politics. Health and the AMA have been at the centre. But the last 2 years that I have served are not what I thought they might be. Perhaps naively, when I thought of being AMA President, it was with the anticipation of being part of a constructive debate around health policy. The AMA is always proactive in policy development, but you also have to respond to the times and the policies that the government puts on the table. Why I feel a sense of disappointment of the last 2 years is because it has been a period of lost opportunity in health policy. At the same time, it is with pride that I reflect on the AMA's advocacy, not only on behalf of our members, but on behalf of our patients. I believe in Australia's healthcare system, and it is with pride that I describe it to people from abroad, most of whom respond with envy. From my first speech at the National Press Club, I have laid out what I believe are the foundations of our healthcare system: universality, equity of access, a highly trained medical workforce, a balance between the public and the private systems, community rating, and the sanctity of the independence of the doctor-patient relationship. It is these foundations that make our healthcare system the success that it is. These are the principles that are worthwhile fighting for. So when the 2014 federal budget was delivered, less than 2 weeks before I became AMA President, the course of my presidency was set. It was clear that the AMA membership was very unhappy and wanted us to oppose the government's co-payment plan. In my first meeting as AMA President, I met with the Health Minister, Peter Dutton, who delivered an ultimatum. As I see it, he said, the AMA can either support the government's co-payment plans or you can be on the outside. It was an easy choice. I was not going to sell out our members, and I certainly wasn't going to abandon our patients. We lobbied hard, and when we met with the then Prime Minister, Tony Abbott, after some discussion, the Prime Minister asked us to develop an alternative to the government's co-payment. we dutifully did this. We worked hard, we kept it in confidence, and we delivered it personally to the Minister. In return, the Minister ignored it. And when we finally released it publicly, he called a news conference to describe our plan as a cash grab by greedy doctors. So much for working with Minister Dutton. And without recapping the whole history of co-payment Mark 1 and 2, let's just say it didn't work out well for either the Minister or the Prime Minister. And after the first leadership spill, we had the pledge from the Prime Minister, Tony Abbott, that there would be no changes to health policy without consultation with the medical profession. After the second successful spill, it seems that unfortunately the new Prime Minister, Treasurer, not to mention the Health Minister, didn't get the memo. Since that time, we have had more cuts. In Maor late last year, with pathology and diagnostic imaging being the new targets. Again, no consultation, no discussion, no warning. We supported the pathologists and radiologists. We campaigned against the cuts to the bulk billing incentives. And as we recently discovered, the pathologists have struck a deal, but I don't think it's something that the pathologists will be celebrating. Then in the recent budget, we had more cuts, with an extension of the freeze to patients' Medicare rebates for another 2 years to 2020. Again, no warning, no discussion. And I have talked with the Health Minister many times about the freeze. I have raised it with the Prime Minister as the number one issue when he came to see us at the AMA. The Minister reassured me of her efforts to lift the freeze. As part of earlier discussions that I had with Prime Minister Abbott and Minister Lee, there was a clear commitment that any savings that were found, particularly through the MBS review, would be used to lift the freeze. The extension of the freeze is not the action of a government intending to lift it. As confirmed by the Minister for Health this week herself, the health portfolio is not run by the Minister for Health. It is run by Treasury and Finance, and it is something that I've been saying for the past 2 years. The Medicare freeze has rightly angered many of our members and many of our patients. Despite attempts by some to paint our opposition to the freeze as simple self-interest, the patients now understand that it is their rebate, not the doctor's rebate. The freeze is affecting not only the viability of general practice, especially those in low-income and disadvantaged areas, it punishes all people who already pay a fee, as their rebate is frozen too. It is bad for Indigenous health, including Indigenous health services that are dependent on the rebate from bulk billing. It affects immunisation rates for children, as parents with multiple children defer seeing their GP. This policy makes no sense. The freeze is not just about GPs, it is about the out-of-pocket expenses for patients seeing a specialist or undergoing medical procedures. It affects the whole of the health system. And a few days ago, I visited a practice in Eden Monero. The GPs were pleased with our advocacy on this issue. Our Medicare freeze poster was up in the waiting room, framed. At the end of their consultation, these GPs were talking to their patients for a few minutes about the impact that the Medicare freeze will have. And this is happening right around the country now. I am pleased that the Labor Party has committed to lift the freeze from the 1st of January 2017 if elected. I know that this is a major commitment, and it is also the result of intense lobbying by the AMA. To the government, I would say it is not too late. It is not too late to recommit to indexation of the rebate, to work with the AMA and achieve health policy that is in the interests of Australia's future. The 2014 budget was not just about the co-payment or the freeze. It was also about the future of our public hospitals. Now, whatever your opinion might be about the $57 billion in funding cuts over the decade, the fact of the matter was that the 2014 budget changes to the funding formula to base Commonwealth contributions for health funding to states and territories on CPI and population growth was going to be inadequate. My greatest fear, and let me tell you it was fear, was for the patients in the smaller states and territories, where these funding changes would have dire consequences for their health systems and for their patients. The AMA has spent 2 years lobbying government on this issue. We have worked with state premiers. We have highlighted the consequences using our annual public hospital report card. That lobbying has borne some fruit. We welcome the Prime Minister's announcement of an extra $2.9 billion, but we question whether that is enough. As the election campaign continues, we await the opposition's announcement of its commitment to public hospital funding. I have been critical of the lack of vision for our health system. We need a clear vision for what our healthcare system should look like in 10 years. What are those needs going to be? This is the first question that we should answer. Having said that, there is policy being developed and the profession is willing to participate. The AMA has always supported the MBS review, but what we didn't agree with was the narrative used to justify it, one which again vilified doctors. I was not going to sit by while general characterisations of doctors were being made as doctors performing unnecessary or harmful procedures on patients simply for financial gain. We participated with the Primary Healthcare Review and it was a successful review and the recommendations have widespread support. The problem is that the recommendations remain unfunded. You can't just talk about the importance of general practice and primary care. You can't advocate for general practice to better manage chronic disease when you provide only $21 million in funding for a trial and at the same time take out $925 million through extension of the freeze. The rhetoric has to be matched by the funding. The history of the last 2 years shows that this government does have a problem when it comes to health policy. But the problems are not the making of the AMA. They are not the making of an outspoken AMA president. The failures of this government are of their own making. A failure to consult with genuine intent, a failure to listen. Most obviously to me, the problems in health are a result of the triumph of short-term fiscal measures over long-term policy vision. From the outset of my presidency, I have warned of the motives and strategy that underpinned the lobbying around private health insurers. And I must confess, I have enjoyed this part of my job. It is a stated intent of several private health insurers and indeed their industry body that they would like to influence the decision-making of doctors in the care of their patients. They want a US-style managed care system. The US managed care system is a failure. Doctors and patients must be able to come to the best decision for the particular needs and circumstances of their patient without the interference of a third-party funder. For those of us who work with patients on a daily basis, we know that most cases are not straightforward. Most cases are complex. Patients often have comorbidities, their own social and employment considerations, a set of personal beliefs that all must be taken into account when deciding on the right course of action for them. We must never let private health insurers undermine our healthcare system, whether it be by interfering with the doctor-patient relationship or by disturbing the equity of access in general practice. We need to ensure that we remain endlessly vigilant to the threats of managed care. This threat is ever present and insidious. It will come through overt attacks, but it will also come through gradual changes. We must always maintain this fight for our patients. I hope the AMA will continue to build on the work of our first ever private health insurance report card. It was a critical resource and one we need to champion. Australians who rely on our healthcare system are relying on you to defend against the actions of insurers for whom the interests of shareholders come first and the interests of patients come a distant second. I think it is easy for politicians and for that matter the media, insurers and others to get health wrong because it is so easy to misunderstand what motivates those of us who work in health. As I said in a speech at the parliamentary dinner early on in my term, we work in health not because of self-interest but because we want to make things better. All of you have given up time with your families and your patients this weekend and on numerous other days, nights and weekends for that goal. I have said many times that I can still remember the day when, for me, it became not just about the patient in front of me, but about the patient that came next and about people not becoming patients at all. The AMA has worked on the issues of family and domestic violence, launching a national resource for GPs in partnership with the Law Council. I had hoped that I'd be able to devote more of my time during my presidency to speaking about the issue of child abuse, or what we often term in medicine non-accidental injury. It is something that I see too commonly in my role as a paediatric neurosurgeon. However, I am pleased to say that I've been working with the AMA in New South Wales, as well as the Child Protection Unit at the Children's Hospital at Westmead and the Joy Agency on a campaign called Stop the Clock. Tragically, every 15 minutes in Australia, a child is abused. Some of those children will die. Those who don't die will live with the impact of that abuse for the rest of their lives. It is time to talk about it, and I'm very proud that once again the AMA will be starting the conversation. Our public health advocacy has been as strong as it has ever been. I've continued to be a passionate advocate for improving road safety, partnering with AMCAP on safety technology, including autonomous emergency braking. We have lobbied the government in relation to alcohol policies to reduce alcohol-related harm. We have continued to educate parents on the importance of immunisation, and we have seen to it that those people pushing false and misleading messages receive the attention that they deserve. None. We have promoted the health benefits of physical activity. The AMA has spoken on the health impacts of climate change and advocated for policies to mitigate the effects of climate change. These are just a few of the areas where the AMA has been prominent in its health advocacy role. We do that for our patients in Australia and at times for those overseas. Now, most of the time, it is difficult to identify the individuals that your advocacy may have touched or even saved. There will, however, always be one exception that will stay in my mind. She is 11-year-old Aminata Bangura. Aminata was the first person to be saved from Ebola by Australia's humanitarian team in West Africa. And as you know, the AMA campaigned hard for the government to increase its contributions to the efforts in West Africa during the Ebola outbreak. Not only because controlling the outbreak at its source was the best approach, but because it was just the right thing to do. Now, I can't say if Aminata would have been saved by some other country's medical team or not. All I can say is I'm very proud that her life was saved by our courageous Australian volunteers, and that was in some way, some small way, due to the role of the AMA. Now, leadership is not easy, and as President, I've reflected on the courage of my predecessors and their willingness to take the AMA into new areas of controversy. I know that some members were anxious about the AMA's statements on asylum seeker policy, but there are many, many members who welcomed our approach. The AMA is a peak professional association, and it is often described as the most powerful lobby organisation in this country. With our role and our influence comes responsibility, a responsibility to speak up when governments overstep the mark. That is what has happened with Australia's approach to asylum seekers. That is why I was very proud to hold the AMA's Asylum Seeker Forum in February. Asylum seeker policy is complex. However, the AMA's policy stance is straightforward because it focuses on health. People should be treated humanely and have access to appropriate medical care whenever they are under Australia's care or in detention. Children should not be in detention. We applaud the government's efforts to remove children from detention, and we look forward to both major parties doing more to provide a humane response to asylum seekers. We believe that there should be independent oversight of that care, and that doctors, nurses, psychologists and all others should be allowed to speak out about poor care without fear of legal threat. I am pleased to say that I received this week a letter from the Shadow Immigration Minister Richard Marles and Shadow Minister Catherine King that commits the Labor Party to maintain the Department of Immigration and Border Protection's Chief Medical Officer, to re-establish a panel of independent medical experts to provide advice, to seek to negotiate with the Papua New Guinean and Nauruan governments complete access to the facilities for the Chief Medical Officer and the independent panel, and to ensure that the Chief Medical Officer produces quarterly public reports on the state of health among detainees within the facilities. I welcome this commitment, and there is no reason that any immigration policy has to compromise healthcare or intimidate those who provide it. In the last 2 years, I've met with Prime Ministers, Premiers and numerous ministers. I've had great experiences visiting Gallipoli for the centenary of Anzac with the Turkish Medical Association, experiencing a personal tour of the Houses of Parliament in Westminster, travelling to Myanmar, Argentina and the United States. And when I think about the highlights of my term as AMA President, there are so many. I'm so grateful to have been able to visit the Tiwi Islands and tour remote communities in Central Australia. But if there's one moment that stands out above all, it would be sitting in the dirt at the Gama Festival in East Armand, up on the escarpment that looks out over the Gulf from Carpentaria, talking to Professor Ben Cass and Dr Paul Lawton with Senator Nova Peris about the enormous problems of diabetes, chronic renal failure and the challenges that Indigenous people face. I wish that every Australian could experience the personal growth in understanding and knowledge that comes by frequently speaking with Indigenous people. I have benefited from the advice that comes through the AMA Indigenous Task Force, from touring remote communities and by partnering with groups such as Close the Gap and Nacho and many others. And I was proud of the work that the AMA did in producing and promoting the AMA Indigenous Health Report Card, but was ashamed of what it demonstrated, an unacceptably high rate of Indigenous incarceration that had worsened, not improved, over the past decade. As the report card demonstrates, there is so much more to the gap in Indigenous health outcomes than the diseases themselves. Health is intricately woven with the social determinants of health, our lack of knowledge of Indigenous culture and the history of the relationship between Australia's First Peoples and non-Indigenous Australians that we are yet to adequately address. For the AMA, Indigenous health has been and will remain a priority. It is an incredible privilege and a responsibility to advocate for better health outcomes for Australia's Indigenous people. Now, this weekend you will be voting on a future AMA President, and it's a sign of a healthy organisation that there is strong interest and debate in the future of the AMA and who leads it, and I wish the candidates well. There will be some time for me to thank people on Sunday, but I'd like to take this opportunity to thank the AMA Federal Council for its support and guidance, and in particular the Chair of Federal Council, Dr Bev Robotham, who has guided us very successfully through a period of immense change. Similarly, I'd like to thank all of those who have served on the AMA board, who put aside their parochialism, who are dedicated to strengthening the organisation. And just as we had an inspired choice of Chair of Federal Council, Dr Elizabeth Feeney has been a great Chair of the AMA board. As an AMA President, you are front and centre, but it is a team effort. And I have had a great Vice President in Stephen Parnas, to whom I also want to say thank you. Steve, let me say that you just haven't had enough credit for the work that you have done. We take the power and influence of the AMA for granted, and at times we dismiss it. However, the AMA presidency is arguably the most significant non-governmental role in Australia. We have a reach and an influence that every other profession and other organisation envies. We have unfettered access to politicians without donating a cent to political parties, and the Prime Minister of Australia comes to us. Almost all of the AMA's President's press conferences in the last 2 years have been covered live on Australia's national news channels. Now, that power and influence does not come from any one individual. It comes from the AMA being willing to lead, a well-run organisation and a well-developed policy platform. So, as we start this conference today, I want to issue this challenge to all of you. Let us use this conference to continue to grow this extraordinary organisation. Let us be courageous and exceptional. Let us be the medical profession. Let us be the AMA. Thank you. Thank you. So it gives me great pleasure to now introduce Shadow Health Minister Catherine King, making her third consecutive appearance at an AMA National Conference. Catherine was first elected to Federal Parliament in 2001 to represent the electorate of Ballarat. She was re-elected as member at subsequent federal elections in 2004, 7, 10 and 13. Catherine was appointed Parliamentary Secretary in the portfolios of Health and Ageing and Infrastructure and Transport in the Gillard government following the 2010 election. The AMA had dealings with her on the TGA, food standards, and the Organ and Tissue Authority. In 2013, Catherine was elevated to Minister and was later promoted to Cabinet as Minister for Regional Australia, Local Government and Territories in the Rudd Government. In October 2013, Catherine was appointed to the role of Shadow Minister for Health in the Shadow Cabinet and has been a hard worker in the portfolio ever since. She holds a degree in social work and a Master's in Public Policy from the Australian National University and is currently completing, and may even have completed, a law degree from Deakin University. Catherine has worked in the social welfare sector in Ballarat and in the public sector in Canberra, including as an Assistant Director and Director in the Health Department. Now, prior to entering Parliament, she was a Senior Manager at KPMG's Health Consulting Practice. Please make welcome the Shadow Minister for Health, Catherine King.
Thank you very much for that introduction, Brian, and can I start by acknowledging the traditional custodians of the land on which we gather, and I pay my respects to their elders, both past and present. Can I thank Brian for his tireless work as AMA President? Brian, I think it's fair to say it has been a tumultuous tenure beginning with the 2014 budget. We've not always agreed on every issue, but you have been an incredibly effective advocate for the AMA, its members, and more importantly, the millions of Australians that you serve. I thank you. Stephen or Michael will have big shoes to fill. Of course, Labor looks forward to working with whoever is elected to lead the AMA, as we always have. I acknowledge here today the many past presidents and the international presidents who we have here with us. Finally, also let me acknowledge my parliamentary colleague, Senator Richard D. Natalie, and offer an apology. I'm not able to stay for your speech, but I'm sure I will hear about it. As I start, I want to acknowledge an issue Brian has been particularly determined to raise, and rightly so: the health of asylum seekers and refugees in processing facilities on Manus Island and Nauru. Like the AMA, Labor has been concerned about the transparency of the healthcare that is provided in these facilities. This week, as Brian mentioned, our Shadow Immigration Minister, Richard Marles, and I have written to Brian to outline the steps that a shortened Labor government would take on this issue. That letter will be released shortly publicly. But in short, we would maintain the role of the Chief Medical Officer or Surgeon General of the Australian Border Force. We would re-establish an independent medical panel to advise the CMO, and we would seek to ensure proper access and reporting by these bodies. These steps should ensure best practice medical care in Manus and Nauru, and I thank Brian for his significant advocacy on this issue. This is my third AMA National Conference as Shadow Minister for Health. I am, of course, hoping to be here at your next one in a slightly different capacity. When you were planning this one, you could not have expected that it would land in the middle of a very competitive election campaign. But here we are, 19 days down, 36 to go, who's counting? Of course, health is very much on the agenda in this campaign, as it should be. Voters rate it as the most important issue above the economy, above the cost of living and above national security. That reflects the fact that health and healthcare are fundamental to our capacity to participate in the social and economic life of this nation. But I think it also reflects the huge gulf between the parties on health, and in particular on Medicare. Australians have watched the debate throughout the term of Parliament, and they know that there is a lot at stake on July 2nd. I don't want to today go through in detail the litany of what I think have been the most egregious of the harms the government has done and tried to do to our healthcare system. You know them well. The abandonment of literally any role for the Commonwealth in prevention, the undermining of primary care through multiple attempts at a GP tax and hikes to prescription medicines, abandonment of public hospital reform and then belated attempts to try and claim by putting a fraction of the funding back in, this somehow amounts to reform. cuts to not-for-profit agencies, cuts to dental care, the undermining of affordable access to pathology and diagnostic imaging, moves to privatise the Medicare payment system, and even yesterday the disclosure that the government's contract for the new National Cancer Registry, something widely supported but that contains highly sensitive data such as pap smear and bowel cancer screening results, has gone to Telstra. It's quite a list. Of all of these, I think the most fundamental has been the failure of the now government, when in opposition, to articulate its vision for health and our healthcare system, and to lay out a pathway for healthcare reform, and then to actually go about systematically enacting that in government. At last year's conference, I laid down the building blocks of Labor's vision to ensure that all Australians have the best healthcare and health possible. It included an enhanced role for the national role for the Commonwealth in prevention, strengthening primary care, particularly in general practice settings, but also between primary care, subacute, acute and residential aged care, better integrating our healthcare system and the way we manage chronic disease and at-risk populations across all settings, improving our hospital care, addressing health inequality, particularly for Aboriginal and Torres Strait Islanders, but also for other marginalised population groups, and establishing the long-term architecture for healthcare reform in our healthcare system, embedding continuous improvement in innovation in that system. Identifying these as priorities doesn't mean ignoring other important issues, but I think it is important to be clear and determined about the priorities for healthcare reform early. Trying to fix everything all at once risks achieving very little. We've already made some very significant announcements in relation to primary care, in particular last week. Of course, we announced that a shortened Labor government will unfreeze the Medicare benefit schedule from the 1st of January 2017. Indexation will resume for all items provided by GPs, medical specialists, allied health and other health practitioners. It was no accident that this was our first major health announcement of the campaign. It reflected the importance of primary care in particular in Labor's thinking and Australia's healthcare system. As I've quoted again and again, health systems with strong primary healthcare are more efficient, have lower rates of hospitalisation, fewer health inequalities and better health outcomes. Both the AMA and the college's advocacy have been critical in Labor taking this decision. Sooner rather than later, we know that the freeze will result in less bulk billing and more and higher co-payments. When 1 in 20 Australians already skips or delays seeing a GP because of cost, that is not something we can afford to stand by and just let happen. When our population is ageing and chronic disease is growing, we should be investing more in primary care, not less. Cost is also a barrier for access to medicines. We know that up to 1 in 8 Australians don't fill their scripts because medicines are already unaffordable for them. So our second major health announcement was that a shortened Labor government will scrap the Coalition's increases to PBS co-payments. Under Labor, Australians will not have to pay the extra $5 per script and concession patients the 80 cents per script. These policies come at a price. They are not easy decisions to take given the current fiscal circumstances and competing demands. But in the end, these decisions are about choices and about what you value as a party. Labor has also unveiled a number of smaller health policies, smaller but just as important. Yesterday, Bill Shorten announced that Labor will expand the Deadly Choices program nationwide to help close the gap in Indigenous health. It builds on our earlier commitments to improve eye and kidney health for Aboriginal and Torres Strait Islander peoples. We've also announced significant new investments to tackle ovarian, prostate and breast cancer. These will improve care and support for Australians living with these insidious diseases, as well as fund life-saving research. And on Tuesday, I announced Labor's approach to developing new models of palliative care, which I see as a critical part of healthcare reform. Today I'm pleased to make Labor's third major health announcement of this campaign. Thanks to successive Labor governments, Australia boasts a world-class healthcare system. We achieve health outcomes that are amongst the best in the world, while spending no more than the OECD average. But no healthcare system is perfect, and ours is under increasing strain. Rising rates of chronic disease, an ageing population, and structural flaws that are threatening its universality. If our healthcare system is to meet the changing healthcare needs of all Australians, we must have a continuing process of policy and program development, implementation, evaluation and feedback. But our recent health reform journey has been marked by cycles of boom and bust. 2 steps forward, 1 step back, and sometimes the other way around. Last year at this conference I said, health reform is hard and complex to achieve. It can only occur when it is led by a national government working with states and territories and with clinicians. Health reform takes time and it can be a decades-long process. It needs to be allowed to make mistakes along the way, and it needs to be embedded in our system in a way that survives changes of government. The solutions to some of the big and difficult questions in healthcare go well beyond the life cycle of any one government. The health and hospitals reform initiated when Labor was last in government was a start. Important reforms that had the potential to greatly improve the effectiveness and efficiency of the healthcare system, but many of them did not survive the first budget after the change of government. This boom and bust cycle in healthcare reform is not helping find, let alone embed, solutions to problems such as how do we provide funding and incentives for things the healthcare system doesn't do, like avoiding hospital admissions, for example. How do we fund and value a system that better prevents people getting sick, keeps at bay chronic disease, or manages these patients in a way that better improves their health outcomes? How do we fund care coordination, encourage multidisciplinary team care, provide better access across primary care settings in a way that we can sustain and improve healthcare quality? What are the best mechanisms to achieve more efficient use of our health funding? These and the many more challenges facing our healthcare system require long-term thinking and long-term solutions. That is why I am today announcing that a shortened Labor government will establish a permanent Australian Healthcare Reform Commission. The Commission will assist governments to continuously improve our healthcare system. Like the successful National Health and Hospitals Reform Commission, the new Commission will have a key advisory role. It will develop and evaluate proposed changes to Australia's healthcare system and advise governments on them, including states and territories, and in consultation with clinicians. The Commission will also have a strong capacity to implement these changes. It will be tasked with rolling out agreed structural reforms to our healthcare system, including changes to funding agreements and payment systems. The Commission will be focused on preserving universality, reducing inequality, eliminating waste and duplication, integrating services and improving the collection and use of data. In doing so, the Commission will take on the reform roles of several agencies that the Coalition has either abolished or downgraded. These include the National Health Performance Authority, the Independent Hospital Pricing Authority, the National Health Funding Body, the former Health Workforce Australia, and the former Australian National Preventative Health Agency. The Australian Commission for Safety and Quality in Healthcare will also be rolled into the Australian Healthcare Reform Commission. Under a shortened Labor government, the Commission will also include a new Centre for Medicare and Healthcare System Innovation. It will be charged with developing, trialling, evaluating and implementing new payment and service delivery models that both aim to reduce health expenditure while rewarding and improving the quality and safety of care. The Centre will include the functions of the current MBS review. Unlike the Coalition, however, a shortened Labor government will reinvest all potential savings realised through the MBS review into new models of care. This will be overseen by the Centre for Medicare and Healthcare System Innovation, and one of the first tasks of the Centre will be to provide the government with advice on the best approach to making this occur. It is Labor's vision that the new centre will provide opportunities for new models in primary care, including the current work on patient-centred medical homes, but not exclusive to that. To manage new models to manage chronic disease between primary care, hospital settings, and the opportunity to then roll these models out across the country, where they prove to achieve better quality of care, better health outcomes, and more efficient expenditure of funding. New models of palliative care will be included in this. The Australian Healthcare Reform Commission will report to the Council of Australian Governments through the Standing Council on Health. It will be created through the consolidation of existing agencies and resources from the Department of Health. The announcements that Labor has made in health to date are significant. Unfreezing the Medicare rebate and scrapping the PBS price hikes to protect bulk billing and affordable access to medicines, tackling health inequality for Aboriginal and Torres Strait Islanders, supporting new models of palliative care. Labor is committed to embedding reform in our healthcare system and putting our reform journey beyond political cycles. The establishment of the Commission and the Centre, alongside primary health networks, will provide the architecture for long-term future healthcare system reform. But governments, of course, cannot go it alone. As I've said, real reform must be driven by clinicians and the patients that you serve. So Labor looks forward to working with the AMA, the colleges and your other professional and advocacy bodies. Together we can chart a course forward towards the vision we all share. A truly universal healthcare system that provides high quality care for all Australians. Thank you, and I'll be very happy to take questions. Thank you.
Thank you very much for that speech, and thank you for taking my question. It actually was originally intended for Minister Lee, but I can't see her. So, I'm Michael Glixman, appointed physician delegate and past Vice President of the AMA in New South Wales. Under the provisions of the Border Force Act, medical practitioners, including the former Medical Director of Mental Health for our detention centres, Dr. Peter Young, who has given me permission to identify him here, is being investigated, and phone records and so forth. I believe this use of the Act violates the undertakings given by this government to never use those provisions in this manner. And this is a threat to the independence of our profession and our ability to practice in the best interests of our patients without fear of intimidation. So I have two questions from that. The first is, would you be able to raise this matter with Minister Lee and bring it to the attention of your parliamentary colleagues? And the second question is, will you repeal the relevant provisions of the ABF Act?
Thanks very much. That's a really important question. And the first thing, I read those reports about Peter in the media, I think it was either yesterday or the day before, and I would be really questioning, what is the crime here? I mean, frankly, what is the crime that's being investigated? We were very clearly provided advice when we supported the Border Force Act that the whistleblower protections were there for people in Peter's circumstances. I have grave concerns about what has actually happened in this space. It is my view very firmly that the independence of medical experts who are providing advice and are blowing the whistle on inadequate care should be absolutely sacrosanct. I have raised the issue already with Richard. I'm happy to speak to Minister Lay about it, but I think she will be here at dinner with you this evening and suggest that might be a thing that's probably best done directly with her. But I've certainly raised it with Richard. It is not, as our understanding, the intention of the Australian Border Force Act to be utilised in this way. We are obviously all in caretaker mode at the moment, but it is certainly an issue that we have concerns about, and Richard has expressed those concerns as well.
Richard Kidd, I'm a GP. Patients just pay the gap for their PBS medications. You mentioned that you're looking at new models for Medicare payment. So would you be considering patients just paying the gap for their medical fees?
Very tricky question there, Richard. Thank you. Look, no, we won't be. I know that is something that has been advocated. It's actually a really important mechanism, much as people don't like me to say it, but it's actually an important mechanism for keeping fees low, and it's not something that we would be looking to do. I think it is important that we do have some levers as a government to ensure that we do make sure that there is affordable access, and for us it is one of the mechanisms. I think you would have heard at Senate estimates we did ask some questions about this, and I think, in fact, it might have been, I don't know if it was the Greens who asked some questions about it, it might have been. We actually think it's actually an important overall mechanism that we use to keep fees low, so no, we won't be changing that. Thank you. I can't quite see you here. I feel like I've met most of you before, so my apologies if I'm not acknowledging that. Hi, Rob.
Rob Parker, President AMANT. We've recently had an outbreak of syphilis in Central Australia, Queensland, Northern Territory, Western Australia, that seems to point to a significant failure policy in coordinating effective responses to prevention of infectious disease. We're quite keen to establish a national centre for disease control, similar to the US and Canada. We're just wondering about the Labor's position on establishing such an organisation.
You've raised this with me, haven't you? Yes, he has done that, as has Warren Snowden, because I think you were looking at it being in Alice Springs. Is that, am I reading? No, it
needs to be in Canberra.
In Canberra,
so it's
okay, sorry.
Similar to the American.
So, yeah, okay.
And
sorry,
Canadian.
a broader CDC. Okay.
A national response.
Yeah, okay. The first thing I'd say, I think it is very disturbing that we are seeing, not just in the Northern Territory, but across the board, increases again in the rates of STIs. I think that is obviously, we have dropped the ball from a policy point of view in making sure that we are, in making sure that new population groups actually do understand our very successful messages that we've had both through the 80s and 90s and into 2000. I don't think that's been assisted, frankly, and I alluded to it in the speech before, by the significant cuts that have occurred to the flexible funds. There have been major programs that have been already have had their funding cut or are about to. The Yay program, for example, the Haymarket Clinic in Sydney, which we've actually managed to get some money to announce that we would be saving that. So I think that's important. I think in terms of the overall response, again, I think it goes to what's actually happened within prevention and population health within the department. It really has not been at the forefront. I worked in the department in the population health division for a long period of time under Liz Furler, who may be known to a number of people here. And that whole area, the population health division, really was at the forefront of leading much of the, not only what was happening from a program point of view, but researching, evaluating and developing what the new campaigns were going to be. I have a very firm view that population health prevention needs to be one of the strongest roles of the health department, and I will have a little bit more to say about that a little later in the campaign. Thank you.
Ross Kerridge, anaesthetist from Newcastle. Shadow Minister, the announcement of the hospital and the Health Reform Commission sounds a very exciting idea. However, thinking back, if we go back 9 years, the early part of the first drug government, there was a lot of enthusiasm for reform and perhaps overstretch and overconfidence in the ability of the Commonwealth to be involved in solving every problem, and particularly in service delivery. What lessons have you learnt from last time?
Yeah, I think it's lessons the current government probably need to learn as well. Is that, I mean, I've said this a number of times, is that I don't think there will ever come a time, I wish there was, where we will say our health system is perfect. We just won't. I don't think we can point to any one health system and we say, this is the perfect system, we don't need to reform it anymore, we are done. It is in need of constant reform, and it is in need of, we've got to constantly feedback, constantly look at what we're actually doing, and that's why I think we've had a problem in terms of the sort of boom and bust cycle of healthcare reform. I said in the speech as well, I think that it is a danger when you have governments that think you can solve every problem. You have 3-year terms. You can solve some problems in that term. New problems will come up during that period of time. If you try and fix everything, if you try and have 13 reviews into every single issue, you're basically going to be reviewing and not actually solving very much. It's why I've very clearly laid down in the speech there are areas that I want to focus on immediately. Obviously, primary care reform. We've got to look at the way in which we actually build the architecture of reform embedded into our actual system, so that if I'm lucky enough to be elected, 6 years as Health Minister, whatever that happens, somewhere along the line when I'm no longer Health Minister and no longer, if that's the case, no longer leading that reform, that then there is the opportunity to embedding those reforms and continuing that cycle over and over. So we've certainly learnt that you can't fix everything, nor should people expect us to, because we will fail. Michael.
Well, just the two people that are on their feet, and then
Catherine, I would like to seek an undertaking that Labor will rule out new medical schools and will rule out any expansion of medical student numbers until we have a serious look at medical workforce, maybe even ask the difficult question about reducing medical student intakes.
Yeah, sure. Again, I'm sure that wasn't just the AMSA contingent who just made that clap then. The first thing, I mean, obviously we were very surprised when there was a decision made about the Curtin Medical School. I mean, that decision was made now I think over a year ago, I think, and I think as we said at the time, the concern for us is this contingent of medical students are potentially the first lot of graduating medical students who potentially won't get the opportunity to actually be doctors because we don't have enough clinical training places, and that is really the issue. It's why Health Workforce Australia was really important. It's about the pathway for training, and we've really lost that. I think the department has been continuing with some of the work of Health Workforce Australia, but pretty much most of that agenda runs out, I think, at the end of this year, and I don't know what they're going to be doing next in health workforce and that clinical pathway. I don't think we should be having new medical schools. It is actually, the funding comes out of the education portfolio, not the health portfolio. I don't think we should be having more medical schools. I think we need to concentrate on training the doctors that we have got coming out of our medical school, making sure in particular we have enough of them going into general practice into the area and into the other areas of workforce shortage and having those pathways. We know or are aware that the government seems to have made noises about a new medical school. We'll wait to see what they're actually going to do. I don't think they're going to actually make that announcement. I'd be surprised. Thanks, Michael.
Thank you for your speech. My name is Kingsley Faulkner. I'm a surgeon. I was president of the College of Surgeons a decade ago.
Hello.
My question to you is, the United Nations and the Lancet Commission suggest that the 21st century, the greatest risk for health will be climate change. I note that the AMA has come out on the issue. In my view, not strongly enough so far, but it's a contentious issue. And I realise it's polarised this community across the spectrum, in this room and across the community. But it is a vitally important issue. I'm also aware that the ALP is stronger on the issue than the current government is, but both major parties still seem to be dilly-dallying in terms of the real measures needed to lower emissions. The ALP is still promoting or allowing, or at least not preventing, opening of new coal mines in this country. Unless those sort of measures are put in place, all the emissions reduction targets that you may suggest will happen will be insufficient. My question to you is, how strongly will the ALP be if they do assume government in this area? Because if you do not do better than currently is being done, not only in this country, of course, globally, this country can lead the world in this area as it has in tobacco control. It ought to be leading the world in this issue. Could I ask your response, please?
For raising that very important issue. You may or may not have seen that before the election was actually called, Mark Butler and Bill Shorten announced Labor's climate change policy, which included a cap on emissions, which included a focus again on renewable energy in particular. And I think that has been interesting to see that the ferocity of the climate change debate, to some extent we were expecting during this election campaign, hasn't eventuated. We, of course, had we been still in government, had we not faced such a fierce campaign against our emissions trading scheme, we would today have an effective emissions trading scheme in this country, and it's disappointing, I think, that we've lost 6 years of important policy development in that space. But we have announced the policies in that area, and I think you are quite quite right to point that out. It's not only here in Australia, but internationally, our relationship with developing nations and what is going to happen for the health of those nations that has driven a lot of what we've done in this space. I've actually charged Stephen Jones, who's the Assistant Shadow Health Minister for this area, so we actually have someone who has specific policy responsibility for it. He has worked alongside Mark Butler in the development of that policy as well, so thank you for the question. Thank you for having me.
Thank you, Catherine.
That's all right. Ready? Okay, great. I'll get a present. Thank you. Thanks, sweetheart. Well done.
All right. I think we've got
Oh, we've got to do a photo.
Yes,
okay. Good. Thank you.
Well, thank you, Catherine, and a good time to perhaps put the mobiles on silent. The Minister, I've got to say, I forgot to mention, is actually coming, but she won't be here today. She will be at the dinner tomorrow night, and she will be speaking then. It's my pleasure to now introduce the Leader of the Australian Greens, Senator Richard Di Natale, also known as Dr. Di Natale. Dr. Richard Di Natale is the Leader of the Australian Greens, Senator for Victoria and the Greens spokesperson on health, sport and multiculturalism. The son of Italian migrants, Richard grew up in Melbourne and now lives on an off-the-grid working farm in the foothills of Victoria's Otway Ranges with his wife Lucy and their 2 young sons. Prior to entering Parliament, Richard was a VFA footballer, a general practitioner and a public health specialist. He worked in Aboriginal health in the Northern Territory, on HIV prevention in India and as a drug and alcohol clinician in regional Victoria. Richard was elected as the Greens' first Senator for Victoria in 2010 and became the 3rd leader of the party when Christine Milne stepped down in May 2015. He is the co-convener of the Parliamentary Group for Drug Policy and Law Reform and the Parliamentary Friends of West Papua and the Parliamentary Friends of Medicine. Richard's achievements in Parliament include leading a cross-party push to legalise medicinal cannabis, passing legislation to combat multinational tax avoidance, securing a register of foreign-owned land and water entitlements, and giving voters more choice on their Senate ballot paper. And he's had the courage to take on controversial issues, introducing the nation's first legislation on dying with dignity and hosting National Drug Summit at Parliament House to explore the need to address drug use as a health issue rather than a criminal one. The AMA has had a positive working relationship with Senator Di Natale on a range of issues. Richard apparently makes mean pizza, grows and bottles his own wine, and is a long-suffering Richmond's Tigers fan. Welcome, Richard.
We've got to do something about that bio. That's way too long. Thanks so much, Brian. And firstly, let me acknowledge the traditional owners of the land, the Ngunnawal people. I want to pay my respects to their elders, past and present. I also want to acknowledge outgoing President Brian Owler, and I want to congratulate Brian on his relentless commitment to health advocacy since he's taken on the job. He took on the gig at a very tough time. He was landed with the issue of co-payments, the Medicare freeze, and I think he's been a very powerful advocate for the interests of doctors and patients. But more than that, he's also been prepared to show the advocacy and leadership that's been lacking, I think, in the Parliament on controversial issues like the issues of refugees and asylum seekers. His advocacy on Ebola, again, I think demonstrated that the AMA is much more powerful when it represents broader health interests rather than just the interests of doctors, and I think he's done a terrific job in the role. We haven't always agreed, but we've had a very good working relationship, and I hope that we can continue on that relationship with the next president. So well done, Brian. It's really a great pleasure to address you this morning, and I want to begin the address with a very simple proposition, and it sums up the way that the Greens approach the issue of health policy in this country, and that is that health is actually an investment, not a cost. We've got a debate in this country which keeps framing health as a cost that's unsustainable, that needs to be reined in, but health is an investment. And access to healthcare is an expectation that people have, but it's also a right, a fundamental right. And the question for us is that as a wealthy, developed nation, we've got some choices to make. We can either choose to adequately fund our health system, or we can choose to rein in costs and have a health system that's not funded to provide the services that we know we're capable of providing. Being responsible economic managers doesn't mean pulling crucial dollars out of a struggling health system. And so I want to talk to you a little bit about our vision for the future of Australian health. It's a plan that invests in health. It goes beyond just the notion of dollars to a vision for how we manage the system, how we improve the health of patients, the health of the system overall. So let's give a bit of context to this debate. A lot of debate about how much we spend on health and this notion that it's unsustainable. Yes, since the 1970s, spending's risen significantly, both in dollar terms and as a fraction of GDP, and now we're being told that it's unsustainable. People point to the ageing population, they look to the future, and they say that we've got to rein in spending. And of course, we've seen the start of that. We've got the savage cuts to Medicare through the freeze in indexation. And of course, the thing that gets talked less about, but is no less important, that massive reduction to the funding of our public hospital system. Well, we've got a very different view on both of those issues. Now, yes, we need to spend the healthcare dollar efficiently. Of course we do. We've got to get good value for money out of our healthcare spend. And I've been a very strong supporter of the notion that we should be eliminating those high-cost, low-value interventions that all of us know are delivered in the health system. And we need to see clinicians leading the response to ensure that we identify those outdated, low-value, sometimes harmful interventions. It's interesting though, when you have a conversation with doctors, it's usually in someone else's speciality. We can always identify what the issues are, but often it's going to take some work for us, all of us, to recognise that there are some things that we can do better and that we need to, as a community, a medical community, review practice and ensure that we're providing interventions based on the best evidence. But we've also got this incredible opportunity, new healthcare technologies, new treatments, they're becoming available, and as demographics change, we do know that we've got the opportunity to spend more money on some of those proven health technologies. And we think it's a legitimate choice, not just a legitimate choice, it is the right choice for a nation to be able to provide access to those interventions. I mean, after all, what is the point of having a strong economy if we can't invest in the things that allow us to be healthy and productive? We spend about $70 billion a year on health, federally, and in the last 25 years, spending as a proportion of GDP has grown. Say from 1990, it was about 6.5%. It's roughly 9.7% today. A slow increase in recent years. The projections suggest we might go up by another % in the coming decade. But when you look at how that compares globally, the OECD average is about 9%, so we're pretty close to that. The European average is about 11%. And of course, in the US, you're talking 17% as a proportion of GDP. And of course, that's a system famous for delivering much worse health outcomes and greater inequality. So we've got the means to be able to invest in our health. These are choices. It means making some tough calls. We have been, in terms of the economic debate, and highlighting some of the choices that we can make, we've been leading that debate, talking about ending those unfair tax breaks. And it's really encouraging that some of those issues have now become part of the mainstream economic debate. Multinational tax avoidance, an issue that the Greens took on several years ago, Senate inquiry, now we're seeing legislation in that area. Superannuation, ending unfair tax breaks at the higher end of the income scale, because super was never designed as a system to minimise income tax. It was always to help people live a healthy retirement. Negative gearing, capital gains tax reform. Again, encouraging that the Labor Party have adopted some of our policies in those areas, policies that we've had for a number of years. Big subsidies to the fossil fuel industry, tax cuts in this budget. They're all of the opportunities that we have to say we can do those things or we can invest more in healthcare. And the good news is that Australians actually agree with us. When you look at research that's been done time and time again, people say we're prepared to pay a little bit more. We want to end those unfair tax breaks if it means that we can have a greater investment in health. We had a poll an ANU poll which found that 81% of people thought we should spend more on health and only 6% thought we should spend less. And we think the Australian people are absolutely spot on. Of course, there's a lot more to do, much more to do to get universal health care in this country. We know when it comes to Aboriginal and Torres Strait Islander people, their health outcomes lag behind, as do health outcomes in rural and regional communities, for older Australians, low-income Australians. There's a lot of work to do. So we've got to be committed to reducing those inequalities in the system, and we've got to be clear that to do that we need a greater investment. Let me start with one of the best parts of the system, and I want to talk about broader system reform. Our public health system is something that we should be very, very proud of. It works well, and for those of you who work within it, you know that it provides people with access to care on a daily basis that otherwise wouldn't have the means to do it. Of course, there are problems, but I think fundamentally it is a good system, and Medicare is an asset, something that we should continue to invest in and defend. One of the great advantages of Medicare is that it's a fair system. It ensures that people who need care can access it when they need it, but it also ensures that people can get access early so that symptoms that may go on and develop are caught early and dealt with efficiently. Of course, as a universal single insurer, it has the ability to be able to keep prices down as well. So it's a cost-effective system as well. That's basically why we're saying that we don't support the freeze in MBS payments. We think that the freeze in MBS payments is absolutely the wrong policy response. What it will do clearly is increase out-of-pocket costs for patients. We've heard from a number of doctors who tell us that they are at a tipping point. Doctors right across the country, many of them in rural and regional areas, who are faced with a difficult choice. Do they pass those costs on to patients, many of whom they know can't afford them, or do some of them close their doors altogether? It's a disastrous outcome for patient access, and it will mean that many patients don't get the access and care that they need. So we do welcome the Labor Party's commitment to reinstate indexation. Of course, I need to remind them that they were the party that introduced the freeze in the first place, but clearly to extend that freeze for a number of years will mean that the current system is just unsustainable. And we do implore the government to listen to groups like the AMA, the colleges and other consumer health groups. It's also a cost-shifting exercise. This is the false economics of making primary care less accessible to patients. We just know many of them will go on and access emergency departments which don't impose a cost. So it becomes a cost-shifting exercise away from federal government budgets to state budgets, and meaning, of course, that overall we all pay more. And when it comes to the issue of hospital funding, we are the only party that is committed to reinstating the funding that was taken out in the 2014 Abbott budget. We know that if we're going to protect patients from that cost shifting, which hurts everybody, then what we have to do is ensure that the Commonwealth Government has got some skin in the game. The whole point of those reforms that we supported that were introduced by Kevin Rudd, was to ensure that there was the Commonwealth Government providing some funding for our hospital system so that it had an incentive to make primary care work more efficiently, so it reduces hospital admissions, which we know are at the more expensive end of the spectrum. So we're not only going to commit to returning that 50% of funding of growth in hospitals, to recommit to activity-based funding, and to ensure that we have a $4 billion commitment to hospitals over the forward estimates addressing the change from the 2014 budget. But we think that we need to go a step further. We need to Abbott-proof our budgets, and we need to Abbott-proof our hospitals. And the way to do that is to introduce that funding formula for hospitals in law. See, the great problem is that at the moment, changes to funding for hospitals can be done at a whim. They don't require legislation. And had that funding formula been enshrined in law, it was very hard fought, And finally, we've got a consensus on having the Commonwealth Government having some involvement in the funding of our hospitals. Had that been enshrined in legislation, those changes would not have been able to occur unless there was a decision of the Parliament. And what it means is that we will get the incentives right, that cost shifting that occurs within the current system, we can put an end to that. But of course we've got to do much better, and we certainly welcome the announcement from the Labor Party around introducing a health reform commission. We think that's a positive step, but we want to put a bit of meat on those bones. So let me tell you about our plan for primary care. We all know about the growing incidence of chronic disease. We know that this is an issue right around the world, and here in Australia, 1 in 5 Australians is living with multiple chronic diseases. And of course, the challenge for our system, is to make sure that the system meets the needs of those growing number of patients so that they can not only service their immediate needs and treat their symptoms, but work on a long-term plan and have better coordination of their care. And we're seeing a consensus emerge here. We're seeing within the health sector, policymakers, academics, and so on, a real appetite for reform, and I think that's reflected in the establishment of this group that's been announced by Catherine King today. But we'd like to actually, as I said, talk a little bit more about some of that detail. So we had the recent report of the Primary Care Advisory Group that was led by, in fact, former AMA President Stephen Hambleton, who highlighted the need for a real reform, and that argument was echoed in the recent Grattan report called The Chronic Failure in Primary Care, which again made the case for change and outlined some of the areas in which we could achieve significant savings and benefits for patients. And of course, as a GP myself, I know about many of the pressures that you face. So we've got a number of programs within the primary care system, about $1 billion worth of the PIP program and programs similar to that, some of those Medicare item numbers that are really designed to try and address this challenge, to meet the challenge of chronic disease. There are a number of trial programs and so on. We don't think they've been achieving the sort of changes that we need. So rather than tinkering around the edges, what we'd like to see is an investment of $4.3 billion of new money, which is what we're proposing today, on top of the existing money currently spent on chronic disease management, so that we have a dramatic expansion of our primary care sector to effectively respond to the big challenge of chronic disease. It's basically a program that will propose a blended payment system to complement a fee-for-service. At the heart of it is the proposal around voluntary patient enrolment. We are proposing that voluntarily enrolled patients with chronic diseases attract a payment of $1,000 each per year for their chosen general practice. And they'll enrol with the GP, that money will come with that patient for the general practice, and it will allow them to provide that chronic disease management that often the current system works against. To be able to fund practice nurses so that we can get better care within our general practice community. We recognise that also, despite the expertise and the essential role that allied health professionals play in effective management of chronic disease, they're largely excluded from our public health and Medicare system, and we want to change that as well. We're going to give patients access to their services and give them the best chance of making the health and lifestyle changes that they need. So we're also committing $2.8 billion in new funding to bring allied health into the public system. And we'll do it by bolstering the primary health networks to coordinate the team-based care that these patients desperately need. It allows chronic disease management to be coordinated within a general practice, and so that we can get those referral pathways that we know are so critical. How is it that a country like Australia, with the health system that we have, has one of the highest rates of amputations for diabetic patients in the world? We know many of those are preventable, and had those patients seen a podiatrist regularly, we could avoid those preventable hospital admissions. Similarly, with preventable blindness from diabetes, we need to create the environment that ensures that people with complex chronic disease, that their needs are managed. We're also committing $11.9 billion for the development, working with GPs and the health community, of a national standards framework for the treatment of chronic disease, so that we can help doctors by providing clear guidance on care pathways and best practice outcomes. All of that working with doctors. Now, you contrast this with what the government's doing in this space. They obviously acknowledge that this is an area we need reform. They've established the healthcare home trial, but it's a trial that is woefully underfunded and really lacks any detail or substance at the moment. We're giving, as I said, some substance there. It's a detailed plan. It commits the funding that's necessary, that over the long term we think will lead to savings as we better manage chronic disease and avoidable hospital admissions. Yes, it is a detailed plan, and of course it's not as nebulous as a health reform commission, but you need a bit of courage in this business, and so we're providing a very clear commitment to propose a specific reform to ensure that our health system meets the best needs of patients and is indeed sustainable over the long run. We're also very committed to directly addressing inequitable health outcomes. Now, if you're somebody from a rural or regional area, if you're an Aboriginal or Torres Strait Islander person or someone from a low income, we all know that your health will be much worse than other people. Despite the fact that 1/3 of Australians live in rural, regional and remote areas, we know that the death rates and life expectancy is much higher than in major cities. And we don't believe that your postcode should determine your health. On Wednesday, I announced a Greens Rural Health Package, which is focused on ensuring our health settings are geared to addressing these shortfalls in our system. We're also calling for the development of a national rural health plan to examine and address the inequity in rural health and to ensure that we also invest in rural mental health. And I can tell you that as part of that plan, we won't be proposing any new medical schools. We also know that people on low incomes are much more likely to experience chronic disease than those who are better off. Think of this stat. Those in the bottom 20% of incomes in this country are 5 times more likely to have cardiovascular disease or diabetes than those in the highest 20% of income. 5 times more likely. So our primary care reforms focus on that group. They focus on easing the burden on those who can least afford it but have the highest burden of disease, as does our commitment to reversing the MBS indexation freeze and to give more patients access to affordable health care. Sadly, Aboriginal and Torres Strait Islander people barely got a mention in this year's budget. Not a single extra dollar was committed to the successful implementation of the National Aboriginal and Torres Strait Islander Health Plan. There's a lot of rhetoric in this space, but we are not going to close the gap if we don't provide the funding that's necessary to do it. So we're going to have a lot more to say about our ATSI health plan in this campaign, but rest assured that we are committed to ensuring that Aboriginal people enjoy the same health benefits that non-Aboriginal people do. On the issue of drugs, you heard that that is an issue that we have taken on. I've worked as a drug and alcohol clinician. I know too well the mess that drug dependence can create in people's lives, but we can and must do better. Our system stubbornly refuses to see people with substance dependence as patients in the first place. And we do hold very strongly the view that substance dependence is a health problem, it's not a criminal one. And sadly, as a nation that once had a proud record on this, we are slipping backwards, which is why we are strongly supportive of increasing access to opioid substitution treatments, to ensuring that we get better in terms of the harm reduction initiatives that we are able to provide to people, which is why last week I announced a harm reduction minimisation fund, $10 million a year to trial a range of harm reduction approaches based on good evidence. And of course, in the treatment space, drug and alcohol treatment services are drastically underfunded. Again, we'll have a bit more to say about that, but we need to be able to provide people with treatment and support when they need it. I'm also focused on ensuring that our health system is more responsive to the needs of people at the end of their life. We've got too many families in Australia who are unaware of the wishes of their loved ones, and it leads to a whole range of scenarios, which I'm sure many of you have experienced, that means that a patient's final wishes are not met. And so there's a lot of work that's going on around the country in this space. We absolutely support it, and it's critical that we provide clinicians with the training and support to better meet the needs of patients. Let me enter into a controversial space. We think that people should also be given the option to choose to end their life with dignity if their suffering becomes intolerable. Thank you. There might be a few boos as well. Look, the bottom line is this, is that we as a medical community need to respect the wishes of patients, and I think that we need to stop seeing the issue of dying with dignity and voluntary euthanasia as in conflict with palliative care. In fact, they are part of the same spectrum. And I know the AMA's engaged in a review on this subject. I know that almost 4,000 people have taken part, members, and I look forward to the AMA arriving at a position that says this should be a decision for individual doctors. Let me talk about prevention, and then I'll finish off with a couple of brief points. We all know that the best way to save costs and to keep people healthy is to try and prevent them from becoming sick in the first place. And that's why we are absolutely committed to a preventative health agenda. We know that the rise of chronic diseases like heart disease and diabetes is in large part thanks to things like junk food, soft drink, which fill our supermarket shelves, and the relentless promotion of those products to young people. We are fed up with the influence of those big vested interests in preventing action on preventative health. We support restrictions on junk food advertising to young kids. We think that the issue of a tax on soft drinks needs to be examined. And we also believe in reforms around alcohol advertising, promotion, and indeed pricing, so that we have a more rational system along the lines of a volumetric-based tax. We were very disappointed at the abolition of the Preventative Health Task Force. We would re-establish such a body, but ensure that it is bigger, better and stronger than the previous one. We're also disappointed at the changes to flexible funds, the huge cuts that were made to preventative health programs right around the country, many of them delivering significant gains through local government. Of course, the problem with prevention is that the people who benefit most from it don't know that they've received a benefit, and so you don't have an active constituency. If you've been prevented, if you haven't had a heart attack because of successful preventative health, you're not going to be providing the same political advocacy as somebody who might have just spent 8 hours waiting in an emergency department. The other problem, of course, with prevention is it's long-term, and politicians don't think long-term anymore. They think in 3-year cycles. It's one of the great frustrations that I have in my role. Let me just finish with a few other points. The issue of climate change was raised. There is no greater champion of taking strong action on global warming in the Parliament than the Australian Greens. We'll continue to do so, and I'm more than happy to talk to you about that issue in detail should you wish. That is one of the great health challenges of this century, and for too long we've seen action on global warming as a cost, rather than recognising that there are huge opportunities in making the transition to the renewable energy economy, both in terms of health gains, but also in terms of jobs and investment. Another issue that I took on when I first got this role was the issue of antibiotic resistance, a major challenge in medicine over this century, and we need to do more, which is why that we had a comprehensive Senate inquiry, which I led into that issue. We are supportive of the establishment of a Centre for Disease Control. In fact, we made that policy announcement in the previous election, and we continue to support the establishment of such a centre. We've got wonderful infrastructure that would be able to be a world leader in this space. Finally, on the issue of refugees, simply to say this, we will support whatever measure that any party wants to put in place to improve the health of asylum seekers, and we of course oppose any legislation that seeks to criminalise health professionals for speaking out against abuses. But let us remember this simple proposition: it is the institution itself of mandatory detention of young children which inflicts damage on a generation of people that won't ever be undone, and until we close those camps down, we are inflicting harm on innocent people. So I'll just finish by saying, starting with the proposition I put at the beginning of this presentation, we have to change the debate in this country. Health is an investment, not just a cost. Of course, we should do better in terms of spending our precious health dollar, but every cent should be reinvested back into the health system. It's an investment in our economy. It means that people are more productive. It means people are happier and live longer, more enjoyable lives. And we commit to ensuring that through this health reform process, that we have a health system that's more equitable, that's universal, and that's affordable for everyone. Thanks very much. Some questions? No time?
We've got time for one question. Is there any burning question that someone wants to ask? Just one. We're over time.
Good morning. I am Dr. John Parikh from Sydney. I'm a general practitioner. Senator, it is good to know that you are in medical profession, but I still couldn't figure out how can a podiatrist prevent a diabetic amputation. I just can't understand.
By regular screening of pedal pulses, and in fact there's some very good data, published clinical data on that a regular referral to podiatrists allows interventions to be performed earlier and leads to lower amputation rates. I'm more than happy to share some of that data with you.
Okay.
Good on you.
All right.
Thanks.
Thanks, Richard. Do you have pop that down.
Thank you.
Thanks,
Good on you.
Cheers. Well, thank you again, Richard. Ladies and gentlemen, it's not a national conference without the AMA National Conference Awards, and we have a couple of important ones to present now. Now, we're just going to reorder the program just slightly. We're going to do the AMA Indigenous Peoples Medical Scholarship. It is, I think, one of our favourite awards, and as chair of the AMA Indigenous Health Task Force, I take a very strong interest in the AMA Indigenous Peoples Medical Scholarship. It was established in 1994 and it aims to help increase the number of Indigenous doctors in Australia. Valued at $9,000 for each year of study, the scholarship provides support and encouragement for Indigenous students studying medicine. The winner of the 2014 AMA Indigenous Peoples Medical Scholarship is Darren Hartnett. Darren has worked as a registered nurse for many years and has always enjoyed looking after people. After travelling to Burma and seeing firsthand how he could make an impact on less fortunate people's lives, Darren has started to think about how he could help his own Indigenous family. Studying medicine has helped him realise his dream. Knowing that within the next few years he could be out in the community assisting people, Darren feels very proud of being a Kamilaroi man. Darren is now in his third year of medicine at the University of Newcastle and is currently supporting himself and his family by working casual nursing shifts. Darren hopes that the AMA Scholarship will lighten the load between work and study as he moves closer to becoming a doctor. We wish him every success. Please congratulate Darren Hartnett.
I'd just like to take a couple of minutes of your time. First of all, I'd like to just acknowledge the traditional owners of the land, past and present, that we're meeting on today. Firstly, thanks to Prof and the AMA for this award. I feel very humbled standing here amongst some very talented people, of which I'm aspiring to be at the present time. I'd also like to thank Sandra Riley and also Elise Merritt that work in the shadows, of which this award wouldn't be here without them. I grew up in a rural area, not too far away from here actually, and I wasn't aware of too much about my heritage until after my grandfather had passed away, and that's when my father told me how he'd grown up in a mission farm up near Maor. And it was quite sad actually when I first heard my dad talk about it and break down, and the fact that he hadn't been able to speak about things. So today I'm very blessed in the fact that I'm quite proud to be a Kamilaroi man, and so are my two little boys that are growing up as well. As Prof alluded to, I went to Burma in 2008 as part of a cardiothoracic team helping do procedures for underprivileged, and it was then that I started to think about maybe I could do some more at home here. Hence my journey into medicine began. Where will I end up? I'm not sure at the moment. Critical care has been in the forefront of my nursing career for the past 15 years or so. But I've enjoyed being out in the rural areas as well. But what I would want to be part of though is to see equity within the healthcare system. Finally, I'd just like to leave you with a couple of words that my dad used to always say to me. He was a very good track cycling coach in his day and didn't say a lot, and when he did say something, you listened. But one of the things he always used to say to me was, imagine, believe, achieve, which later I found out after he passed away himself that he'd pinched that from Mark Twain. But it's certainly words to live by, and for me at the present time, standing here in front of you now, I've actually achieved the first one and I'm in the process of doing the other two. So thank you very much.
Fantastic. Okay. The next award is the MDA National Prize for Excellence in Medical Research. This is an award of a cash prize of $10,000 for the best research article published in the Medical Journal of Australia in the previous calendar year. The winning article this year, The Crux of the Matter, Did the ABC's Catalyst Program Change Statin Use in Australia, was authored by Dr. Andrea Schaffer, a biostatistician in the Faculty of Pharmacy at the University of Sydney, Nicholas Buckley, Professor of Clinical Pharmacology at the Sydney Medical School, University of Sydney, Associate Professor Timothy Dobbins from the National Drug and Alcohol Research Centre at the University of New South Wales, Professor Emily Banks, Scientific Director of the 45 and Up Study and Head of Chronic Disease Epidemiology at the National Centre for Epidemiology and Population Health, Australian National University, and Professor Sally Ann Pearson, Head of the Medicines Policy Research Unit at the Centre for Big Data Research in Health at the Faculty of Medicine, University of New South Wales. The winning study was a population-based interrupted time series analysis of a 10% sample of Australian long-term concessional beneficiaries who were dispensed statins under the Pharmaceutical Benefit Scheme, about 51% of all people who were dispensed a statin between the 1st of July 2009 and the 30th of June 2014. Dispensing of protein pump inhibitors was used as a comparator. The main outcome measure was the change in weekly dispensings and discontinuation of the use of statins and PPIs, adjusting for seasonal or long-term trends overall and, for statins only, stratified by the use of cardiovascular and diabetes medicines. The researchers found that in their sample of 191,833 people were dispensed an average of 26,946 statins weekly. Following the Catalyst program, there was a 2.6% reduction in statin dispensing, equivalent to 14,005 fewer dispensings Australia-wide every week. In the week the Catalyst program aired, there was a 28% increase in discontinuation of statin use, which decayed by 9% per week. An estimated 28,784 additional Australians ceased statin treatment. Discontinuation occurred regardless of the use of other cardiovascular and diabetes medicines. Following airing of the Catalyst program, the researchers concluded that there was a temporary increase in discontinuation and a sustained decrease in overall statin dispensing. Up until the 30th of June 2014, there were 504,180 fewer dispensings of statins, estimated to have affected 60,897 people. Even though the observed effect was relatively small, the prevalence of statin use in Australia and the established efficacy of these drugs mean that a large number of people are affected and may suffer unnecessary consequences. MDA National has generously sponsored this prize, and here on their behalf is Dr. Dror, Maor, along with the Laureate Professor Nick Talley, Editor-in-Chief of the MJA. On behalf of the research group, we welcome, hopefully, Dr. Andrea Schaffer. Oh, good. Associate Professor Sally Pearson and Professor Emily Banks. Please welcome them to the stage, and Dror and Nick will present the award, and I'll call on the recipients to say a few words. Thank you.
So, ladies and gentlemen, it's a great privilege to be the Editor-in-Chief of the MJA and to award this prize. The heart and soul of the MJA is great research. This was fabulous research from Australia, research that showed television can change practice, and really important research for the future in terms of the impact of journalism, perhaps sometimes unbalanced, and also the importance of understanding that impact in terms of healthcare. So congratulations to the winners. And it's a privilege to invite Dr. Dror Maor to come up as the MDA National Rep to say a few words too.
Thank you, Prof. Talley and Professor Alla. It is my great pleasure to represent MDA National as the chairperson for the President's Medical Liaison Council and present a cheque of $10,000 to the winners of the MDA National Prize for Excellence in Medical Research. As a doctor-owned mutual since 1925, MDA National is part of the profession, and one of the reasons we really have continued to support this award over the past few years alongside the MJA is because it acknowledges the invaluable work and research within our profession. The winners of this year's prize, as indicated before, wrote a very interesting article, and a great article which I highly encourage you all to read. Even from an orthopaedic background, I found it interesting. So on behalf of MDA National, it's my privilege to present Dr. Andrea Schaffer with the MDA National Prize for Excellence in Medical Research for 2015, and please accept this cheque on our behalf.
Thank you.
Thank you.
So we need to face over here, Brian. Face over here. I'll go on the other side. And we need to make sure. There's Andrea. There you go. Please hold that. Hold it up. Squeeze in tight. There we go.
Right,
perfect.
no one fall off.
Please don't fall off. Thank you. Congratulations. Very well done. Please.
Just going to say a couple of words. Oh, thank you. Oh, thank you very much.
Thank you very much.
Really appreciate it.
It's an honour to receive this prestigious award, and I think I speak on behalf of all our co-authors when I say that it's very rewarding to see our work recognized in this way. So I want to say thank you to the MJA and MDA National as well. I was very proud to be involved in this work, not just because it represents high-quality research, and as well as an important message locally, but it's also received international recognition because it's the subject of the effect of the media on public health behavior, in particular statins, has really been a topic of interest around the world recently. This work was only possible because we had access to timely linked administrative data, as well as a talented multidisciplinary group, clinicians, epidemiologists, and biostatisticians. So once again, I just want to say thank you very much.
Congratulations, well done.
Well, thank you, Brian. This conference would not occur without the support of sponsors, and I would like to acknowledge on behalf of the AMA our gratitude to our sponsors, and in particular our platinum sponsor today, Synapse Medical. And I would want to introduce to you Margaret Foe, lawyer, founder and principal of Synapse Medical. So Margaret is a lawyer and registered nurse who's been involved in Medicare claiming for 30 years. She's the founder and CEO of Synapse Medical Services, one of the largest medical billing companies in Australia, and is a published PhD researcher on the topic of Medicare claiming and compliance. She's currently completing her doctorate at the University of Technology, Sydney, in the Faculty of Health, where she's examining the experiences of medical practitioners in relation to their Medicare claiming and compliance obligations. Margaret is a regular presenter on the topic of Medicare claiming and compliance and has appeared on ABC Radio to discuss Medicare reform, and she's regularly asked to comment in relation to the Australian health sector reform. She also contributes regularly to Croaky Health blog as a member of the Croaky Health and Medical Panel, and is an active member of Medical Software Industry Australia. Margaret is committed to assisting doctors to understand the operation of the Australian healthcare system, and as an entrepreneur is constantly looking to develop and tailor innovative services to streamline the efficient delivery of healthcare services. Please join me in welcoming Margaret from Synapse Medical.
That was a very long introduction. I would like to thank the Chair. I'm going to make it shorter next time. I'd firstly like to acknowledge the traditional custodians of the land on which we gather and pay my respects to the elders past and present. I have been allocated 10 minutes. I've been informed I can go as long as 11. But I'm not going to talk for anywhere near that long because I know never to get between a doctor and a plate of sandwiches. So, as you've heard, I'm the CEO and founder of one of Australia's largest medical billing companies, Synapse Medical Services, and we are delighted to be the platinum sponsor of the AMA conference this year. I would personally like to thank the AMA for giving us this opportunity. Synapse is an Australian good news story. It was a startup operating with 3 people from my second bedroom in January 2010. We are now a proud SME with a global presence in the UK, North America and India, and we have a team of just under 100 people in 4 continents. We have 3 offices and are expanding rapidly. And in addition to billing, we now offer transcription, appointments and bookkeeping, and our client base has expanded to include hospitals, both public and private, and larger corporate entities. What inspires me to work for you, the medical profession, is the Australian thirst for innovation. We have more mobile devices than people in this country. And Australian doctors have implemented a variety of amazing innovations in patient care over the last 10 years. Think clot-busting treatments for strokes and robotic surgery. But what's interesting to me is that whilst the med tech sector has made rapid advances, the medical administration sector has not. It has not lived up to your innovative zeal. It remains cluttered with paper, as most of you know, till now. Synapse has been offering doctors in Australia the innovation that they deserve. We have developed Australia's first and most comprehensive patented medical billing app, which houses a rules engine based on extensive research, 30 years of experience, and a deep understanding of the legal and administrative framework of Medicare, but not just Medicare, the private health funds, the Private Health Insurance Act and regulations as well, the workers' comp and third-party insurance arrangements. It's like an amalgam, if you like, of the science behind Australian medical billing and the legal framework on which it rests. So this is not just the MBS in an app, it's much more than that. Anyone can program the rules that they can read in the MBS, as long as they can understand them. But not everyone can program what's not written in the MBS or in the legislation or the regulations. And we are committed to programming all of what we estimate to be about 1 million medical billing permutations, one by one, for as long as it takes. It's these labyrinthine rules hidden in the code that is what doctors need. The app's obviously available on iPhones, tablets, Android devices, and it allows doctors to bill at the point of service, and it ensures that all the required data is there, including details that the rules engine knows Medicare and the health funds will need in order to process your claims. For the doctors in the room, it's all those things you don't want to think about at the time of service, like the patient's signature on the DB4 form, whether you can add fees for consumables or not, the timing of a second consult on the same day, and the fact you can't bill a 133 unless you've billed a 132, and the list goes on and on and on and on. So your claim rejection rate drops, you get paid for the work you do on time. It also means for the first time you're mobile and not stuck at the office computer. It helps you to be compliant with Medicare, and you have recordings of your activities all the time and assurances that you haven't forgotten anything. And for those of you sitting there thinking, oh yes, but I bet I have to enter all the data and that is a pain, that's a pain that only maybe a proctologist could understand, I say to you, photograph it. We have an innovation within the app allowing you to photograph patient stickers and front pages of files, which we then convert into text within hours. Because Synapse not only has innovation, but a workforce as well. And that's what sets us apart. We don't just have software, we have people. We're not just the car, but the driver as well. The AMA conference here in Canberra has given us an opportunity to launch our latest innovation, which is software as a service. This is essentially our app separated from our workforce, because we realise that many of you have your own staff already and may not need Synapse to do the legwork for you, but you may still want to use the app and its rules engine. So we've developed and are launching today a SaaS model of the app that allows data that you obtain on your home visits, ward rounds or theatre lists to be captured and made available on a secure website, which your own staff can export and generate the bills. And we're very proud to tell you that the app also has Australia's only fully compliant mobile bulk billing function in Australia. So no more carrying around DB4 vouchers for those home visits. The patient can sign on the screen of your phone. Now, I just want to quickly chat for a moment, I'm almost done, about outsourcing more generally. I was in the UK the week before last, where I attended a meeting with a consultant who's working with the clinical commissioning groups, or CCGs as they're known. These are the organisations who contract NHS services for GPs. The consultant described to me the work she was doing with her organisation in trying to encourage and assist GPs to share infrastructure so that they can cut costs and remain independent. She gave the example of a CCG sitting here managing contracts for 20 GP practices, all of whom were employing the same administration staff to do the same task, which might be, say, answering the phone. And she was encouraging them to share the cost of a reduced number of staff to do the same work. It's a space that Synapse is actively seeking to engage in various parts of the English-speaking world. And in the face of pressured global health budgets, this type of outsourcing may be an important component in helping practices, including Australian practices, remain viable and independent. For those of you concerned about outsourcing and privacy, a quick word. Synapse is the only Australian billing and transcription company that's been ISO certified for our quality management system. We are seeking certification on 27001, the data security certification this year, and we adhere to all Australian state, federal privacy laws. And as a practicing lawyer, obviously that is something that I take very, very seriously. We go to great lengths to protect the data, the sensitive data that we hold, including biometrics, access control. All our data is stored on servers here in Australia, and our systems offices and servers are protected by the highest level of security. We have CCTV cameras everywhere, and I watch those cameras on my laptop from anywhere in the world. Now, I'm just going to tell you now about a few cool things, fun things that we have here at the conference to just give you a break from formal proceedings if you're so inclined. So first is we have a Sunday morning breakfast session. We're going to do two things at that session. The first is we will demonstrate the app. So for those of you who come along, you'll download the app, we'll give you a username and password, and we'll let you play with the app. We'll show you the new software as a service model, and you can play with the bulk billing function. The second thing we're going to do is talk about outsourcing. So we'll talk about the advantages and disadvantages and examine what practice functions can be outsourced. We'll examine the risks and answer that very important question. Does outsourcing really save you money? And we'll present facts, figures and case studies on successful outsourcing and some unsuccessful outsourcing stories. Plus, of course, we have a quiz. Some of you may be familiar with our great MediMind quiz. So you can win an iPad today. We're giving away a second iPad tomorrow. So 2 iPads are up for grabs. All you have to do is correctly answer the Medicare claiming question of the day correctly. So every year at all conferences we attend, the quiz generates heated competition and a lot of requests for appeals. But I've made the questions easier this year. And I know that many of you will know the answer. In fact, all of you probably know the answer to today's question. It's a dead easy bulk billing question. So there will be a winner today. So we'll draw the quiz today, I believe, at 4 p.m. and a little earlier tomorrow. Just 2 more giveaways. We're giving away $100 worth of free transcription to everyone who visits our booth. I was going to say any doctor that visits the booth, but anyone who visits the booth, if you have transcription needs, you can have $100 of free transcription. As long as we're typing in English, we can type it. And we're also giving away a free 14-day trial of our app to everyone who visits the booth. So please come on over, say hi to Marcus, who's standing up the back of the room there. He'll set you up with the app and the billing freebies. So that's it from me. Many thanks for taking the time to stay in the room and listen to me, and I look forward to meeting many of you over the next couple of days.
Well, thank you again to Margaret, whose company Synapse Medical is the platinum sponsor for the National Conference, and congratulations on a very engaging presentation, Margaret, and knowing how desperate we all are for sandwiches. So here we are at the end of this morning's session. We're now well into National Conference, and you will have read your programs by now and have noticed that it's really an outstanding program we have over the next 2.5 days. May I remind you that any notice of an urgency motion must be lodged by 1 o'clock today. Lauren, to my left at the minutes table, and we can now break for lunch in the Murray and Fitzroy rooms, and proceedings will recommence at 1:20 this afternoon. Thank you.